I'd like to introduce the panel that's stepping forward, and this is part of our addiction team at Mayo. And why we're wanting to discuss teamwork and why we're calling this a master class is that we all feel very fortunate to practice here, where the Mayo brothers, in the founding of the clinic with the Sisters of St. Francis, had a notion of team practice. And this is what Mayo prides itself on, that we can put the needs of the patient first when we have several heads put together thinking about how should patients be treated from a multidisciplinary standpoint. And so on our panel, on your far left, we have Susan Persons, who is a nurse who has worked in the psychiatric field in several locations over many years, beginning with the Federal Medical Center, and then coming to Mayo Clinic, where she worked in general psychiatry and has also worked in addictions. Recently has made a change into working more directly with medical patients and bringing this perspective of the nursing role on the addictions team. In the middle, we have Ms. Jennifer Gifford, who is a master's level licensed alcohol and drug counselor who has worked in several locations across the upper Midwest. She's seen a number of systems. She is truly our systems person of where can this patient go in the region to be in a program which best meets their needs. I'm delighted too to work very closely with Jennifer at the Transplant Center, where she has increasingly developed this role of the addiction counselor working with patients that have end-stage organ disease. And on your far right is Mr. Brian Flick, who is a licensed social worker, part of our addictions team, focusing on the psychosocial needs, particularly social needs of patients as they come into addiction treatment and taking on more acute psychiatric problems or psychologic problems that need attention comorbidly as a patient is beginning their addiction treatment. Our group has no disclosures. Briefly, the learning objectives is to identify the potential interaction of some of these roles. And what I encourage you to think about is in your institutions, and some of you may be working very directly with addictions and an addictions team. Some of you may be working more peripherally with addictions and have not had as much contact in discussing how to identify and manage addiction problems, and to think about how multidisciplinary teams may apply to your practice or how this could be strengthened for your patients' needs. Our first question: why might a multidisciplinary treatment team provide optimal care for patients with substance use disorders? So pull out your clickers again. The first option, the complexity of healing body, mind, and spirit. Second is the psychiatric model or biopsychosocial model of care. Third, ASAM, the American Society of Addiction Medicine's 6 dimensions of care, or all of the above. Okay, you're quick. And you're smart. So good. So an overview. We have the multidisciplinary treatment at Mayo, and these are the primary members of our multidisciplinary team, though we'll talk more about other members that help out, and then we're going to discuss 2 cases. When patients come to Mayo for an outpatient addiction evaluation, we have a tag team, starting out with the RN and the LPN, who will do the initial assessment, and Susan will be describing this process to you, then passing the patient off to the licensed alcohol and drug counselor, and finally the addiction psychiatrist, the MD in the team, discussing the patient with the licensed alcohol and drug counselor, and then interviewing the patient individually and putting together the plan. Our residential treatment is similar, though we have a more expanded team, which also includes recreational therapists and a chaplain, and sometimes other team members. And then our outpatient continuum of care, we continue to have ongoing nursing input, social work input, and then counseling and physician input. Rationale for a team approach. All of you got this right, but we are complex as humans, and we cannot forget this in dealing with addictions. Otherwise, we're going to truly miss an opportunity to be able to take on patients and their complexity, if we think that all the problems may be related to the substance use and not looking at the developmental history, the medical problems, the comorbid psychiatric disorders that are going on, where there may have been self-medication to begin with before the onset of the substance use disorder. The American Society of Addiction Medicine has developed the 6 dimensions of care. Often these need to be determined by either an individual or by a team in determining placement or level of care. And when we have a team working together, obviously we're going to be able to best make determinations about issues of intoxication or withdrawal if we have medical staff, nursing staff who are making those assessments. Staff with backgrounds in emotional, behavioral, and cognitive health who are able to inform Dimension 3 in determining how intensive a level of care is needed, in addition to 4 through 6, which are primarily the focus of the training and the assessment by the licensed alcohol and drug counselors. So with that, I would like to shift to the team and have each team member introduce themselves and talk just briefly about what they see as their role on the team. I want to go ahead, Susan.
So nursing is actually the first staff members that will interact with patients who are coming in for either a chemical dependency evaluation or later on if they're coming into our intensive addictions program, our 30-day residential program. So what happens is the LPNs will obtain the vital signs, a breathalyzer, and a urine drug screen for us. After that, the RN will interact and we'll just glean some information about their general health. However, there are times when that breathalyzer is significantly elevated. I've had people who were 3 times the legal limit. So that puts a stop to the evaluation process. So at that point, what would happen is the nurse would do a withdrawal symptoms, a CWA on the individual. We would ask when their last drink was, how much did you have? Is that within your normal pattern? And then we would need to find someone to stay with the person. I want to know, did they drive? Do they have a driver? And once I get another nurse to stay with the patient, then I would go and talk with the counselor, who in turn will interact with the patient, followed by the addiction psychiatrist. So at that point, with these significantly intoxicated patients, then a decision has to be made. Do they need to go to the emergency room, or are they able to go home with family and come back at a later date when they are able to interact and not be intoxicated for the evaluation? But if this was just an individual that we have a very low breathalyzer or a negative breathalyzer, then what the RN would do is we would check what their current medications are. We have to get that list updated. I want to know when their last drink was, what they had, how much, within a 24-hour window, and as well as their last benzodiazepine usage, the last sedative usage, and their last opioid usage. The reason why we ask those 4 questions is I need to evaluate, does this individual need a withdrawal assessment done, either CWA or a COWS done for opioid withdrawal. And the other thing I need to know is what is your withdrawal pattern? What are the symptoms of your withdrawal? Have you had seizures in the past? Have you had DTs? Have you required medications to get through the withdrawal process? We also evaluate for suicidality. And we also review the major medical issues. How is this individual dealing with their medical issues? Are they able to manage their own cares? Can they actually ambulate well? Are they able to take their own medications? And just the activities of daily living, because if they go to our 30-day residential program, they have to be independent. They have to be able to manage their own medications and do their own self-cares. So if, in fact, that is not the case, I see somebody very debilitated who needs assistance to the bathroom, etc., that's part of what I would pass on in my report to the counselor. And that, in turn, will be evaluated by them as well as the addictions psychiatrist. There are other times where it becomes a bit of a challenge where if they're coming in for an admission to our intensive addiction program, the residential program, I have one instance that comes to mind where the gentleman, I always ask him, would you like a drink of water as I'm working with them and interviewing them? And he said, I'd actually like a glass of ice. So I went out to get a glass of ice. I brought it back to him. And lo and behold, as I handed him the ice chips were jumping out of the cup. So I thought, oh, okay, this alters what I'm going to do here. So obviously I did a CWA, did the withdrawal assessment. I asked him when his last drink was, how much he had had in that 24 hours, what the recent pattern had been. And then I contacted the addictions psychiatrist who came, evaluated him, and made the decision he would be transferred immediately to the emergency room, that we could not wait the hour or perhaps longer for the hospital admission. This man was in that much of substantial withdrawal. So sometimes you're making judgments on the call and on the fly, but those are some instances that have happened in my evaluations. Now, what do the LPNs do? The LPNs are there 24/7 in our residential program. So the RNs work a day shift, but the LPNs are there around the clock. And what I see the LPNs doing is they monitor the patient's medications. They are able to take their own meds. The LPNs will record that they've done that. They observe interactions in the informal settings. They notice and note behavioral changes. So if there's erratic behavior, they can do a random breathalyzer, and actually we do random breathalyzers every 24 hours, but they can do that, an additional one, and they can also call for a urine drug screen as well. So then the report would be given the following day to the team, and they can report changes in mood and behavior and concerning interactions amongst the peers on the unit. They also assist in supervising anti-abuse administration. So the LPNs are really kind of the supportive people. They're the face around the clock. And with that, we'll talk a little bit more what the RNs do later in the case studies.
The role of the licensed alcohol and drug counselor, LADC, is really taking that lead as the primary counselor and as the case manager, whether they're coming in for an assessment or if they're coming in for treatment. We are really tasked with obtaining that comprehensive chemical use assessment, not just the last year, but we look at an entire lifetime of use, being able to provide that to the physician and the team in a way that's very concise and complete. We also look at how their use has impacted their daily living, maybe their family environment as well. We're the ones who obtain the collateral information, do some investigation into what family and friends have said about their use. And then we also make recommendations. If we see a patient that has not been able to stay sober for a long period of time, we might recommend a residential level of care, or we might even have some options for an outpatient level of care. We also meet the patients where they're at when they come into treatment. We want to get their goals. What are they looking to accomplish while they're here? And then we take those goals and develop with them a treatment plan. We introduce them to the norms of the community or to the group process. And we introduce those basic recovery skills, asking for help, helping each other out, so that they can live in a community together. Additionally, we facilitate all the group therapy processes. Really there, we're connecting patient experiences, helping them find other people who've had similar experiences, have done similar things, so that some of that shame and guilt can be relieved. We also work on having them practice identifying and experiencing emotions in a sober environment. We also do extensive components of the education for our patients in treatment. We are doing education on understanding the disease of addiction, on behavioral management of cravings, identifying and managing triggers and high-risk situations. We are also looking at the process of relapse, the stages, and how do you prevent relapse. And then finally, one of the biggest things we also do is work with family. We are there to be supportive of family members, but also to give them education on how they can be supportive of the patient. So it's kind of the role of the LADC.
Social work. So the social worker takes a clinical mental health focused role. That being said, within the context of the biopsychosocial model and in collaboration with the entire team. The clinical social worker is able to bring this person-centered perspective and really this able to acknowledge psychosocial circumstances that are part of the overall symptom picture and part of that patient's life. The multidisciplinary team is sort of like the social worker's natural habitat, so it kind of fits in pretty well, working with multiple different providers, and the benefit is all under one roof and one unit rather than outside referrals and things. So we're able to bring this larger context in and pull from multiple different sources of information for the patient. So social worker will be involved in some groups, teaching skills, doing some structured groups, individual psychotherapy, psychosocial assessment, team meetings. They're involved in supervision and team rounds. So multiple different areas that they can pull information and bring it back to the team so the team can really make a collaborative decision. So yeah, we do some of this group psychotherapy in each level of care. There's multiple levels of care, and using an evidence-based model, typically, this base of CBT, but also acceptance and commitment therapy, dialectical behavioral therapy skills, mindfulness-based sort of cognitive therapies, and really, again, with a focus on skills training and getting them to be able to really participate in the primary addiction treatment. So really working to address barriers, this dimension number 3, emotional, behavioral, cognitive complications, working on addressing these barriers so that they can function at the most optimal level for, Jen's groups or the other LADC's groups. And one of the other neat things about the social work spot here is the ability to follow patients throughout these different levels of care. As their needs change, the social worker can change the approach, be more thoughtful about that, and the kind of incremental approach to skills development. For instance, when they first come in, we want to work on a lot of education, identification, understanding emotions, that sort of thing. As they move into more outpatient, they're staying at home, coming in maybe half days. We focus in on some of the practical application in real life, really go even heavier on the skills. And then as they move forward, less and less time in treatment, in group therapy, more and more ability to sort of fine-tune some of these different approaches. Typically different issues that we work with, anxiety, depression, but also trauma-related, as you might well know, personality, and sort of working to help tease some of these things out, because we can work with people 6-7 months. So that's a big benefit as well.
So you might wonder what the psychiatrist does if that's all done first. And sometimes there isn't too much left when we go through the evaluation process. As I mentioned, we have physician-directed teams, and where I see the evaluation process for the psychiatrist as part of it is diagnostic, in that we complete a full psychiatric evaluation and are able to look at different symptoms, whether or not they represent substance-induced mood, anxiety disorders. It may not be clear whether it's substance-induced versus a primary mood disorder. Teasing out issues of underlying psychosis, if they're possibly there, bringing out in the psychiatric history potentially issues of trauma. Part of what is very helpful about having several professionals have their eyes on the patient is that there may be varying levels of disclosure, depending upon whom the patient is most comfortable with, varying levels of resistance. If the patient has been very resistant along the way and talking with the nurse, talking with the LADC, it may give me a clear indication of needing to work primarily with motivational enhancement. What is the patient here for? What are they willing to do? How can we take them the next step? For patients coming into residential or outpatient addiction treatment programs, the role of our addiction psychiatrist is to be following along the addictive disorder and the progress in treatment and interventions that are appropriate for the patient, and also monitoring the psychiatric disorder, perhaps beginning psychotropic medications, psychotherapy, directing them to social workers or psychologists who are continuing with psychotherapy. So what we'd like to do is talk about a few cases and how we might apply this. And I would encourage you to think about these cases, similar cases that you might have seen, and how a multidisciplinary team fits into treating these sorts of cases. We're going to begin with this one. Our patient is Mrs. Johnson, who is a 45-year-old married white female, mother of 2 adolescents, who works in business management and lives in suburban Minneapolis. She presents for treatment after her husband threatened to leave and pursue divorce in full custody of their children. He recently learned of an incident of marital infidelity during the patient's Wednesday night out with her friends. She attributed the affair to a blackout and acknowledges upon admission into treatment that this incident, quote, was not the first time, unquote. She has been a daily drinker for at least 5 years and consumes 6 to 10 standard drinks on Wednesdays, Fridays, and Saturdays with loss of control. She has tried unsuccessfully on several occasions to reduce or stop. Last drink was yesterday. Mrs. Johnson reports a family history of alcoholism and her mother's sexual abuse by a teenage cousin from age 11 to 12, and episodes of depression and cutting during high school. She completed college with honors and a master's degree, though reports intermittent lowered mood and binge drinking while in college. She has undergone 1 trial of fluoxetine 3 years ago after her mother's death. She is unclear of benefits and was actively drinking at the time of that medication trial. She reports depression and is uncertain whether she even wants to remain in the marriage, which has been increasingly estranged, though hesitates to leave because of her children. As we say, people are complex, and this isn't an unusual presentation to admission to our program. So let's go through our team members and how each one might conceive of what could I bring to this case and how could I help this individual. Want to go ahead, Susan?
We would be doing withdrawal symptoms as ordered by the psychiatrist. I would be inquiring how the individual is sleeping and how they're adjusting to the unit. For this woman, she would need to contact her primary provider to discuss the need for STD testing, and if that would come back as positive, that she needed some medications just to assure that the orders were sent forward and that our addictions psychiatrist would be in agreement with that. Now, this individual sounds like she would be motivated to get her own appointment set up, but what I do discover is with many of the patients who are in our residential program, they've been non-compliant with medications and they've neglected their health for a long time. So taking the responsibility of making their appointments is kind of different for them. Perhaps someone else in their life has been managing those details. So what the nurse is going to do is to remind them that you'll need to contact them and just check up and make sure that that's happening. So sometimes with the more ill patients who may have some liver damage, that they may have some memory issues, and it's trying to figure out, is this person capable right now of making that appointment, or are they just used to having other people manage their life? So it's trying to understand that and follow up and make sure that those medical appointments are taking place.
One of the things about having the nurse on staff is that they really do a lot of that self-efficacy, so patients are getting the care that they need, and we get to take advantage of that as the counselor. In this situation, I'm really looking at kind of an ongoing assessment of whether she's appropriate for the program, making sure that she is able to establish healthy boundaries with her peers and group. We're looking at her level of motivation being primarily external, and so we're starting to look at what have been the pros and cons of her use, if she's able to identify those. And we're also going to really spend a lot of time working on what are the signs and symptoms of her disease, helping her to identify that, kind of identify the development of the disease over time, so that she can better manage this disease long term. We're also going to be looking at some real basic things like how does she manage cravings? What are the high-risk situations? Her peer group appears to be a group that drinks, and is that going to be a risk to her ongoing recovery? Those are going to be kind of those initial things that we start out with in the treatment plan.
From a social work perspective, the first thing that we typically do with this type of patient, which isn't very uncommon, this is a kind of a fairly common patient, we would work to identify and establish safety, given all the stressors that she's currently going through and a history of trauma. We'd want to look at any self-injurious behaviors or suicidal ideation, that type of thing. That being said, moving right into distress tolerance skills to be able to be in the group and stay present within the group would be a primary focus right away. You know, this particular case, you can see the trauma piece on there. Oftentimes, and it's not uncommon as well, is the first-time disclosures of traumatic events, sexual abuse, physical abuse, emotional abuse, etc. And, well, we don't want to primarily focus right in on that. If this is a first-time disclosure, we need to be there for them to validate, reflect, and really help them have or give them a safe avenue to share some of this information and be acknowledged that, you know, this wasn't okay. And oftentimes, being able to do this, maybe just seeing people 1 or 2 times, their participation in group will go way up, their anxiety will go way down, and they'll be able to really work with the LADC counselors a bit more. With this patient as well, we probably, if she didn't disclose right away, if this was further down the line, right away I would kind of keep referring back to Jen, keep referring back to the LADC to focus on their addiction treatment, get that really zeroed in as a focus so we can separate the two, look at addiction, and then look at mental health. Then towards the end of treatment, see how they might interact and where that goes.
Thank you. Where I think, you know, this case is so clearly representative of many patients that we see is that it can be hard to know where to start. For those of us working in addiction, we can see this high-dose drinking and negative consequences. And she came into treatment. Her goal is to save her marriage and to keep her kids around. We may see the real problem based upon, you know, the particular angle we have from our field of training. What's important not to miss here, and this is where our team can keep talking about the big picture, is this lady came in and the psychiatric genetics person may be saying, wow, her mother was alcoholic, 50 to 60% risk of alcoholism. Those of you who are therapists would see, you know, this woman had a mother who was alcoholic. Maybe there was neglect during her childhood. Maybe there was a role reversal as she was caring for this alcoholic mom. And then she was sexually traumatized, and she had significant stress tolerance issues during her adolescence. She was cutting. You're thinking about maladaptive personality traits, a personality disorder, which may have continued over time. We're seeing that she suffered with depression and that she may have untreated depression at this point in her life. She has marital problems. She has a peer group where she's going out drinking. She has probable compromise in her personal beliefs and sense of integrity in these extramarital relationships, which may have set her up for disease exposure, but certainly have likely affected her self-esteem and willingness to even talk about these things as she comes into treatment. So there are all these different layers. And as much as, you know, we hear that there needs to be dual diagnosis treatment and you treat everything at once, which is a partial truth because we can't treat everything at once and not everything can be the priority. But certain things are critical. As Brian points out, if this is her first disclosure of this past abuse or trauma, that needs to be heard and it needs to be validated and she needs to know that she's supported. And that certainly has been our current experience in treatment, as probably many of you have seen, simply bringing that out often frees people up to then put that on the shelf for a while they're just focusing on getting sober and beginning to get their life back on track. When you have a full history like this, and you think about it in terms of the 6 ASAM dimensions, you can see why this lady would make it to a residential level of care. And so when you have that multidisciplinary team pulling out those pieces, perhaps patients more easily get to that higher level of care that they're going to need to begin putting the pieces back together and addressing the problems and putting people in a safe environment where they can begin to heal. I'm going to forego the second case so that we have our full lunch, 45 minutes, that we can get back on track at 12:30 with our next presentation. But again, what we had hoped to do is to get you thinking with this part of the presentation about how do teams work and how can we look at our patients' best interest and pull in our colleagues. And if you're having to work solo, as so many people in the community are working solo with addictions, particularly addiction counselors, to think about, which social worker could I pull into this? Which nurses are available in the clinic that could perhaps do a fuller assessment with me when that's necessary? Is there a psychiatrist, an addiction psychiatrist that you could be pulling in as part of your team? In seeing this as rounding out patient care, because none of us can do it alone. Well, thank you for your attention.